Hi, good evening, everyone. So, welcome to the session where I'm going to recall the SS paper in the cardiology section, especially the NEET SS group for the cardiology questions. Let me, before analyzing the questions and giving you the answers for them, let me take you through the brief outline. A lot of students had given, and I think our other faculty have already taken this discussion as to how the paper was different from what it used to be for many other sessions that have been there for the previously in the NEET SS. And this time there were a lot of questions that were not typically expected in the format that you expect the NEET SS to be. So there were a lot of questions which were highly high in content with regards to section on pediatrics, a lot of questions from gastroenterology. But the cardiology, I can tell you, is pretty consistently been the questions that are classically expected and were true. So let me then take you through the questions, important questions that were there, and whatever we could recall. First of all, let me thank all of our students who have shared these questions and recalled them with the appropriate options. Remember, the disclosure is that there are a lot of questions which are ambiguous in recall. Some of the students may have forgotten to tell us there are all the correct options. So this is based on whatever could be recollected and shared with us by our students. And based on that, I'm trying to take you through the important questions of the cardiology section, especially that was asked and can be recalled. One of the simple question, usually, again, this is a high yield topic, which I usually tell cardiotoxicity and on cardio oncology. This is one section that is a high yield topic apart from cardiac tumors, where usually either or of the two would yield one question. And again, this time they asked you a question which was specifically about uh, trastuzumab for CA breast. And the question was, which of the following is true regarding cardiotoxicity of this drug? The options that were mentioned, that it's reversible, it causes myocyte destruction, whether it's irreversible or dose dependent. That's how the recall was. A lot of students are live. If there are any inputs that you have, you can share it on the chat box, and I'll try to answer that query as well. So this question, pretty much, it was easy that the trastuzumab cardiotoxicity is usually reversible. It's not permanent, and that's why it's preferred over the classical other anti-cancer drugs because of the beneficial effect that it tends to have cardiotoxicity, which is reversible. If you go through the options, as I said, trastuzumab induced cardiotoxicity is reversible. Irreversible destruction is characteristic of anthracycline induced cardiotoxicity, type 1 toxicity, and trastuzumab causes what is called as type 2 cardiac dysfunction, which is characterized by functional impairment without permanent cell damage. And while cardiac dysfunction may develop during or after treatment, it often improves with discontinuation of therapy and initiation of cardiac failure. Now, which of the following is wrong? If that's the question, then irreversibility would become the option. If it was framed as it is framed and shared with us, then it would be reversible. So basically, trastuzumab actually causes reversible cardiotoxicity. So irreversibility is, if all except was asked, then it would be irreversible, which would be the right answer. So reversibility, cardiac function typically recovers after the cessation of therapy. It involves disruption of HER2 neuroguanine signaling pathways of cardiac myocytes rather than direct cell apoptosis. And it's unlike anthracycline toxicity, this is not dose dependent. It is irrespective of how much dose has been given, whether it's first dose or multiple dosages, and the risk factors for development of trastuzumab induced cardiotoxicity is prior anthracycline exposure, older age, hypertension, and pre existing cardiac disorder, including previous baseline abnormality. And hence, regular EF monitoring is what is recommended in the same. So, Ujjwal, Himanshu, Avila, everyone is saying that the question was asked in the fashion that which of the following is not true, in which case you need to choose from the options based on this. The recall that we could collect from our students and from our team was in the fashion that I've shared with you. So whichever option was not true. If that is the case, then it's of course that the toxicity is reversible, not irreversible. That's how the option has to be chosen. There was another ECG where was confusion was about recall was whether the patient had inverted P waves or not. That's very important to realize, because if you have inverted P waves, then you probably are dealing with dextrocardia and also the poor R progression from V1 to V6. But a lot of students have recalled that this was actually limb lead reversal and not dextrocardia. Other options were artifact and RVH, which would probably not hold true. This is one of the ECGs that I thought will share, probably not the same ECG. But I think AVR was positive, AVL was negative, as most of the students have recalled. You can again put a message in the chat box if that's correct recall by most of the students, and the P wave was upright. So, in case in the leads which are positive, like lead 3 here, the P wave is upright, AVF with P waves are upright, in which case you need to confirm that this is situs solidus. So remember, P waves go with situs. The upright P wave goes with situs. So if the P waves are upright in the right left-sided leads, it tells you the situs. P waves upright always tells you the situs. So posterior fascicular block was another option, is what Ajay is saying. VVM is saying it's not dextrocardia. Limb bleed reversal was correct, is what Abhi is mentioning. AVR was negative, is what Madhu Sudharan is answering. But a lot of students have told me that AVR was positive and AVL was negative. One all true except an ECG was limb lead reversal, everybody's saying. So practically, you just look at the left arm, right arm reversal, you will predominantly show a negative QRS complex. Lead AVR will show a predominantly positive complex. Lead 1 will be negative, and that's how you recognize the arm reversal. The reverse polarity of 1 and AVR would suggest left arm, right arm reversal. Limb lead reversal, left arm, right arm reversal leads, AVR, AVL will be reversed. And so whichever leads are interchanged, that's how you determine. And of course, V1 to V6, you'll have normal QRS progression. That's how you realize it's a limb lead reversal. So a lot of students are confirming that it was limb lead reversal. AVR, AVL, both were positive, is what Dr. Dhamik Doshi is saying, in which case you need to look at lead 1. So if lead 1 is, so which leads are being reversed will determine which axis will turn negative, which limb lead will show positive or negative. So if P wave was upright, it is situs solitus, then dextrocardia isolated is unlikely to be asked. Situs solitus dextrocardia is very unlikely to be asked, because situs solitus dextrocardia usually goes with complex heart disease. So complex congenital heart disease is the common association if you have situs with dextro. Solitus with dextrocardia. So usually dextro would go with situs inversus, and in which case P would be inverted all across the leads. So AVR positivity was given and poor R progression was given, is what Varun is saying. And there was P inversion in V1, is what Uzair ul Haq is saying. So I think ultimately a lot of students have told me that it was a limb reversal upright P, and one of the two leads was interchanged. Was it AVR or AVL interchanged with one, or the other way around, is the confusion that a lot of students have about the recall. Uh, so again, Ankur is saying that if what I mean, if for the question 1, the option were all are correct except, then the question would be wrong, because one can recollect options were the same, so there can't be two incorrects, which is correct. So you cannot have both reversible as well as irreversible as the option. So that it would become a bit confusing. Uh, uh, so all of the following was false except was the framing, is what Ankur is again confirming. So again, I've just tried to cover that concept of situs solitus versus situs inversus and limb reversal in an ECG patient. So I think cardiology section, relatively compared to what was asked in pediatrics or gastroenterology, was pretty much straightforward. A lot of questions were people were not even able to recall those segment of questions. That's what I've been told. And that's why this time it took some time for us to get a good recall done from the cardiology perspective. Question number 3 was about a 21-year-old male presenting with acute onset chest pain, ECG showing ST elevation in 2-3 AVF and V5, V6. Echo showing concentric hypertrophy. Now, if you have these two findings present, you have hypertrophy and you also have ST elevation, Between the choices that were given, tricyclics, antihistaminics, chronic cocaine overdose, and antipsychotic therapies, the answer would be chronic cocaine, because cocaine causes hypertension, and it also causes, because of that, concentric LVH, and it will also, because of vasospasm to the vector directed towards the inferior plane, would usually be, and multiple lead elevation would usually be a feature of coronary vasospasm in a patient with chronic cocaine overdose. But again, I would like to know your recall as to how it goes. This is again the answers why it is a mismatch feature in this case. Tricyclics typically causes QRS widening. Brugada type ST elevation, though, however, can occur. But then they should have mentioned a clear-cut QT prolongation, which was missing here. Primarily, antihistaminics can only cause torsades. They don't cause ST elevation. They cause it because of QT prolongation, especially if they are non-selective ones like loratadine, etc. The classical fexofenadine and the newer generation of antihistaminics are less likely to cause QT prolongation, though. Antipsychotics cause more of cardiomyopathy and QT abnormality, again, not ST elevation MI pattern. So, as I said, cocaine dual mechanism, uh, vasospasm in acute setting with multiple involvement of multiple territories, and also LVH would best explain that this was a case of cocaine, chronic cocaine toxicity. Any confusion about this question and its framing and recall? Because I think all our faculties have been telling that the recall has been this time pretty much the mixed bag, because a lot of students are not able to recall either the correct framing or even the correct options that are mentioned with it. So I think for this one question, at least there is no controversy. It was pretty much easy, straight away framed question that it was actually a chronic cocaine usage. Right. Santosh is saying there's no confusion about it. Again, about the tracing, a lot of students were confused whether it was actually mitral stenosis tracing or not. The pressure and time was all mentioned. They did not mention what chambers were there, though I've here tried to show LA versus LV. But I think the label was missing in the exams. Uh, and I think the pressure values were also missing, I've been told. ECG was also probably not shown. But this is what kind of diagram was mentioned here. And this is classical of mitral stenosis, because that it is showing a gradient, usually a polygonal, usually a irregular shaped gradient, which has maximum value at the beginning. Then it tapers off. Then it again rises because of the LA contraction, further contributing to the gradient across the mitral valve. Transmitral gradient, if it is present, as you know, the classical hallmark of mitral stenosis is end diastolic transmitral gradient. So if there is any gradient which is present at the end of diastole, usually that would uh, suggest a tracing of mitral stenosis. So I think this tracing was also pretty much the same. Uh, I'm getting a lot of comments by Ariba Nassar that ECG was shown, sir. Okay. And so if the ECG was shown here, then it means that the pressures, even pressure values were given. So shading was not there in the diagram. So that doesn't matter, because if they don't give you a shading, means they don't want you to pick it up. But if the pressure tracing shows A, C, and V waves of LA, and it shows the diastolic pressures of LV, and there is a gradient between the two, then you're probably dealing with a mitral stenosis. Um, ASAR were not the options. Again, the options recall is not there. I've been told that these were four valvular, and this is from what the question options you have shared with us. Again, SB is saying ECG was not shown, while Ariba is saying it was shown. Again, issue with the recall. But this is the same tracing they are saying, which means it is mitral stenosis. So end diastolic transmitral gradient is a hemodynamic hallmark of mitral stenosis. Presence of any gradient here is a feature of mitral stenosis. If it's there, then it's mitral stenosis. So that should have been pretty easy one. Question number 5. Which of the following is true about cardiac resynchronization therapy? Again, a lot of recall issues. I've got only three options recalled by students. Fourth option has not been recalled. Option A was there is mortality benefit only when defibrillator is present along with CRT. Option B was equal benefit for both RBBB, LVBB, and C. It increases synchrony without increase in oxygen demand. Now, between these options, the right answer is the oxygen demand, because mechanical synchrony improvement is required because of the contraction. I usually explain to my patients, like, this is your fist is the uh, uh, left ventricle. Then instead of all synchronously five fingers contracting, you get three first and the rest two later. So this type of dysynchrony is what exists, and for that to be corrected, it's what it does is it gives current in a fashion that reduces the mechanical dysynchrony to increase the cardiac output. And this has been shown that the myocardial oxygen demand does not increase in various studies. And there is a quote that I've shown the study name. Also, I've put it as 14 in the reference section. Between LBBB and RBBB, we all know it's the LBBB, because that's where the RBBB actually will not cause dysynchrony between the septum and the posterior wall, because RBBB will have the conduction running from the left vesicle, and the left vesicle will still depolarize first, but the two hemifesicles, the septum, and the dysynchrony between the septum and the posterior wall would be there in the LBBB, will not be there in the RBBB, because it's the right side where the supply is lost. So for RBB benefits, however, the benefits are very limited. You'll have to prove it that there is echocardiographic LV dysynchrony present. So this was one more question that a lot of students were not able to recall properly, as to which of the following actually is a good modality to assess LV dysynchrony. I think that question I've not included here, but I think a lot of students were asking about that option. Then the investigation of choice between the modalities that were mentioned would come to be echocardiography. So best modality is ECG, followed by, amongst evaluation, would be an echocardiography, where you measure the time delay between the septum to the posterior wall delay. So septum to posterior wall delay can be measured by ECG gated echocardiography. The uh, uh, dysynchrony, which is mentioned with mortality benefit, while CRT with a CRT-D, it reduces mortality in ischemic cardiomyopathy. CRT with pacing alone still improve survival, and thus option only defibrillator will not be correct. Uh, uh, I think the question that Jinka is saying is echo should be done before documenting dysynchrony was the other option. So before that would not be the case. Echo, that's mandatory only for our, as I mentioned, if the LBBB is not significant enough. So QRS duration more than 120 for LBBB, more than 150 for RBBB. If there is no dysynchrony, then you need an echocardiography to support the same. So right answer is CRT, enhancing the ventricular synchrony through optimized AV delay and reduced activation delays. These improve hemodynamics with reverse remodeling without increasing oxygen demand. So that was the right answer. That brings us to the next question, which was about syncope and a young patient. So, young patient presenting to OPD with syncope has a family history of sudden death. True regarding the management. Here, avoiding high intensity. So, very likely, young patient, syncope, sudden death in family history. You probably are looking at a case of hypertrophic obstructive cardiomyopathy. That's most likely caused because of the prevalence in number itself. As you all know, HCM prevalence is nearly 1 in 500, and that's a clinical diagnosis. Echocardiographically, it may be even more. So 1 in 500 is a high prevalence rate for HCM. It's often undiagnosed. Avoiding high intensity sports is the right answer, because beta blockers are the drug of choice. Digoxin cannot be given. It actually increases the gradient. So drugs that are contraindicated in HOCM include anything that reduces preload, will reduce the LV size. Anything that reduces afterload will again increase the gradient, and anything that increases contractility will also be contraindicated. So drug contraindicated would be nitrates, digoxin, and ACE inhibitor, or for that matter, ARNI and any other group of dilators. Even dihydropyridine type of calcium channel blockers. Beta blockers are fundamental in management strategy now. Mavacamtan may soon be available in our country as well. It's already available in West. The other drug that you often use to reduce the gradient is disopyramide. So disopyramide beta blocker is usually the most often used in obstructive cardiomyopathy as the drug of choice, and hence avoiding high intensity sport would be the right answer or option in this question. Uh, the echo image of HCM was given in the question, I'm being told. So that would confirm that this was a case of HCM that you were dealing with. And then the option uh, uh, would be that answer. Family history of sudden death, as I said, especially young age, you should think of inherited cardiac disorder like cardiomyopathy or ARVD or long QT. But again, the physical activity would be contraindicated in all of them, even if the image was not given. If image is given and it's a case of HCM, then it goes on pretty much easy to understand that you're dealing with it, and in the high intensity sport is to be avoided. Preventive measures, as I mentioned, evaluation would be important. Beta blockers are often used, and digoxin is not recommended. So that was pretty easy, straightforward question from HCM. If you could see the image, echocardiography, I always say important images are HCM image, SAM image, image of amyloidosis, which again was asked as another question in multiple myeloma, where you had a case of amyloid, cardiac amyloid. So I think they've pretty much gone as to expected lines. This was probably the other image. Multiple myeloma patient presented with shortness of breath, NACO. The options was frequent blood transfusion is a risk factor associated with beta MHC, MYH, or ECG will meet criteria of LVH, and RCMP is most common. So you have speckled appearance of the septum, because that's the classical, and you have what is called a pseudo infarction pattern on ECG. So ECG would show the disarray of the septal fibers would not yield an R wave in the mid precordial lead, and it looked like an old anterior wall MI, and septum would appear thick. So thick septum but poor R wave. This is classical pseudo infarction pattern of cardiac amyloid, and that's why RCMP is the most common presentation would be the right answer, which again Bina and everybody is confirming on chat box right now. So the correct answer is restrictive cardiomyopathy is the commonest presentation of multiple myeloma. That's because of presentation being cardiac amyloid from light chain deposition, predominantly causing restrictive cardiomyopathy and diastolic dysfunction, which is the clinical scenario here. So blood transfusion, while multiple myeloma may require, but there is no evidence to say that transfusion increases risk of multiple myeloma. Beta MYH is part of HCM, not a part of RCMP or multiple myeloma. Cardiac amyloid, common complication. Thickened walls, as I mentioned, low QRS complexes by Sokolov line or Cornell index. And as I said, this is the classical presentation of what is called as a pseudo infarction pattern, which you can pick up on a dysynchrony or dissociation between ECG and echo. Echo shows thick septum and there is no LVH. And that's how you diagnose. And the most common cause in these patients would be associated cardiac amyloidosis, which is secondary cardiac amyloidosis, where you would not be using a the therapies which are used in ATTR type of amyloid, of course. So you need to treat the underlying cause. The other question was about Takotsubo cardiomyopathy. Very much expected angiogram image, LV angiogram image. 58-year-old female heard news of son's road traffic accident, developed chest pain, 2D echo MR show Takotsubo cardiomyopathy. Trop I was elevated, no history of drug intake, normal coronary angiogram. True statement. Mostly occurs in postmenopausal female. She could undergo PTCA, lifelong warfarin required, and after 2 weeks, echo shows apical dyskinesia. Those were the options. Between these options, we would always think of Takotsubo occurring in post-menopausal women as the right answer, because 90% of Takotsubo occur in postmenopausal women. Almost ratio of 9 is to 1 male to female. Again, postmenopausal versus a young female ratio is also pretty high. uh, this 58 is slightly perimenopausal, but usually it's elderly females, 65 to 80 years, strongly associated with estrogen decline. Estrogen deficiency is believed to be one of the pathophysiological mechanism, which increases catecholamine-induced myocardial stenting as a susceptible mechanism how Takotsubo develops, and it's the predominant receptor which is responsive of the beta 1 receptors in the myocardium, which leads to apical ballooning and septal preservation, because of also the dual supply of the vagal as well as the sympathetic cardiac plexus. These two hypotheses suggest why apical ballooning happens. But there is something also called as reverse Takotsubo, which can also develop in these patients. So anticoagulation required was one of the answer, I've been told. But if they had mentioned PTCA is unnecessary, troponin is falsely elevated, angiogram is normal. Anticoagulation is required only transiently, less than 3 months, and that too only if there is thromboembolic risk or patient has developed LV clot, or there is risk factors of high incidence of getting a cardioembolic phenomena, patient is bedridden, etc. So no such indication is mentioned here, and that's why instead of anticoagulation, the right option still would go to be a postmenopausal female, because the preponderance is almost 10 is to 1 for this case for males to females, and again postmenopausal to otherwise is also going to be high. It's also the wall motion abnormality resolves pretty quickly within days to weeks. Apical dyskinesia persisting beyond 2 weeks is also very uncommon. So that way, the option would be post-menopausal women for this question. Another question was acute MR. Now, this is a clinical JVP. Expected one question always comes from clinical cardiology, and this is the question that they have asked here: what kind of a murmur you expect? See, acute MR, so there will be pulmonary acute PAH, and because of that reason, the JVP would be not normal. It will be slightly elevated, and hence normal JVP you would not expect. Also, pulmonary hypertension is pretty likely. Apex will not be displaced because it's acute MR. There is no acute displacement. But because the LA is not compliant, it will be short systolic murmur that you would expect, which will end much before the second heart sound. And hence, the correct option here would be this. So short systolic murmur is correct. That was the option. Acute MR, LA is non-compliant, unable to accumulate the sudden volume overload, results in elevated LA and PA pressure. Pulmonary edema, shortness of breath, murmur of acute MR is often soft, short, as the regurgitant jet rapidly equalizes pressure between LV and LA. This contrasts with chronic MR, where MR is holosystolic. Normal JVP is not there, as I mentioned. Usually, JVP is risen because of PH or RAS strain, and displaced apex does not happen, and hence the right option here was soft short systolic murmur, which is heard. Any questions here about the options? I think options and the three options that were recollected pretty much explain and confirm what the diagnosis should be here. This is a bit tricky question. Now, I think I need your inputs for uh, what were the other options, and more uh, information was provided or not. This is a patient who underwent valve replacement for MR, and ejection fraction improved from 30 to 50%. Prognosis of valve replacement depends on etiology and timing. Both are important. Now, uh, the question is which of the two options to choose will a lot of times depend on whether it's a primary MR or not, primary or secondary MR, what was mentioned here. Secondly, whether they mentioned repair versus replacement. That was the other question. And third, if they've mentioned etiology or not, that also, whether it's a primary, secondary, and if they've repaired or a replacement, what is that mentioned? That's the option that would determine the right answer, because both of these options are correct to some extent. Etiology of MR is important. If you're dealing with primary versus secondary, it will make a difference. Timing of surgery will also matter. If you've done it in acute MR, LV will improve. If you've done in chronic, it may not, because that's when the LV is not prepared. It has to learn to unload, which it will not happen. So for this question, other option was gradient more than 40 is what Ariba is saying. Okay, that probably will not hold true. Primary valve abnormality was mentioned or not mentioned in the after tower. That was the other question, option. The patient underwent AVR. Okay, so if you add AVR, then the things change, because his improved MR. So there is a small study that a lot of students, we had this discussion. There is a small paper that a patient, substantial amount of patients post TAVR continue to have MR, and this MR when tackled after TAVR will improve. That was mentioned. That option will may come as the right answer, but otherwise, if there is no tower mentioned, if there is no tower on this, so one was on MR, one was on AS. That's what some of the few are mentioning. Nagashri is saying there were two questions. One was of MR and the other was AS. Primary valve abnormality after tower MV improved. What should be the cause? So etiology of MR and timing of surgery, both are correct here if you look. Because if you take this line from Harrison, there's only one line. The management of chronic severe MR depends on some degree for its cause, which means the etiology. And hence, if you look at the primary MR, you can see that even if EF is less than 60% and you do a MV surgery, A lot of times in a successful durable repair is possible in degenerative MV disease, where it would be class 1 indication because of the improvement that happens with these patients. But again, secondary and chronic, you probably will not get. And because of this one line, if the examiner is framing this based on this one line mentioned here, then probably the etiology would be the answer. Otherwise, both of them are correct options. After TAVR MR improved, then that option, if it is mentioned in the question framing, I have been told that there are two separate questions and this was one question, then higher etiology would come. But if there was another question where it is a TAVR, post TAVR, there is MR and MR improves, then there are some papers which talk about it, which is one of the paper that's been mentioned in the ACC. So etiology, underlying cause of MR significantly influences outcome. Primary MR caused by structural, generally have long-term better outcomes after surgery due to LV dysfunction or remodeling. Secondary MR often are bad. They don't yield. So acute primary will always yield good improvement. While early intervention before LV dysfunction sets in is also critically improvement. Delayed surgery in severe LV dysfunction, EF less than 30, has worse outcome. So improvement post-surgery, there is a favorable response likely due to timely intervention. Both are important. But again, this question framing is pretty dichotomous here, I would say. For primary MR question, option were EF greater than 50, have less morbidity, is what Jinka is mentioning. So again, based on recall, if there were two separate questions, I've answered both of them. But for this question, etiology, the primary versus secondary would hold the option as to be correct. The one or the other question, this is very simple one. Unfortunately, two questions were asked from cardio oncology. The second one was, which is the most cardiotoxic agent here? There is no doubt everybody needs this. Doxorubicin. This was pretty straightforward and simple question. The option was cisplatin, methotrexate, and paclitaxel. Between them, if doxorubicin is mentioned, you always choose and then anthracycline. Anthracycline is the most cardiotoxic agent, and the whole science of cardiac oncology is based on a lot of toxicities that people have encountered because of doxorubicin. Anand is saying in another question, it was MR prognosis with surgery depends on what. And there was one stating if surgery done when EF is more than 50, then good long-term prognosis. That also is correct. Doxorubicin, of course, here, anthracycline, the incidence is over 20% in some of the studies. It's cardiotoxic is dose dependent, primarily results from degeneration of iron-free radicals, leading to oxidative damage, fibrosis, and permanent apoptosis, what is called as type 1 injury. You had another question, as I discussed as the first question, where trastuzumab will cause type 2, and that was the other framing where whether it's reversible, irreversible, not true, etc. That framing was done. Incidence of cardiotoxicity with doxorubicin can range from 0.9% if the serial echo are done to over 20% in cumulative. Cisplatin can cause hypertension, but incidence is lower. Methotrexate is rarely cardiotoxic. Paclitaxel can cause bradycardia, arrhythmia, and severe. But again, incidence is pretty low. The doses in which it is used and the duration for which it is used is much lower. And that's why the right answer here was anthracycline, doxorubicin. So those were some of the recall questions that we could get the options from you this time. I think the recall was pretty bad. A lot of confusion among students. I think a lot of it came because all of the questions were like descriptive rather than short memory based, rote memory based questions. A lot of descriptive questions, and that's why recall was not so good. But I wish you all the best. At least cardiology section, I can say, was not as bad as some of the other sections. It was pretty much expected. A lot of high yield topics giving a lot of questions. And I wish you all the best. I'm sure that once the results are out and you get a proper recall and the questions are out, probably you will be able to judge yourself as where do you stand. My best wishes are always with you, and we are here to support you. I'm here to support you in whichever way I can, even when preparing for the INI, which is now upcoming. A lot of you can actually are part of the WhatsApp group, and you have the link. If you don't have, you can WhatsApp me as well, and I can add you to the group for the discussion. So, thank you very much. The recalls are coming after a week. The reason being that the questions are not recollected properly. A lot of confusion, and thank you all of you for all the contribution. Ariba is saying thank you everyone. Thank you for contributing. A lot of you have given me a lot of these question feedbacks. Thank you very much, and look forward to connect with you again for any further discussion that we'll have in future. Take care, stay connected. Best wishes for your career in future. And take care. Bye bye. Okay, I will log off now. Vinod?